have the privilege, pleasure, and challenge of speaking to you all after lunch, which means my goal is to keep you engaged and interested. One of the ways I do this is I speak very quickly, so you got to be paying attention to understand everything I'm saying. Part of that comes from growing up in a family of 7 children. If you didn't speak quickly, your words didn't get hurt. So let's begin. A little bit more about me. More importantly than being director of FACS or working as a family physician is my vocation as a wife. I am married to a fellow family physician, Dr. Kenny Lynn, and as a mother. We are parents, blessed to be parents of 4 incredible children. I really liked Bill's reference to the story of Abraham and Sarah. My oldest son is Isaac, named after Isaac from the Bible because he brings so much laughter. My next daughter is Eden. She truly is my piece of paradise here on earth. Followed by Ellis, who is named after his grandfather and great-grandfather, my John, who came through Ellis Island. And then my baby girl, Gianna, because I wouldn't be a good doctor if I didn't name my 4th child Gianna after Saint Gianna. I am very blessed to have an incredible mother who is an incredible role model as a nurse and as a pro-life advocate, and raised us to respect and understand and appreciate the dignity of human life from the very beginning. And as I shared last night, it was November 2nd, 1979 at about 4:40 in the afternoon when I received my call to be a doctor. Most people are like, wow, how do you know that with such precision? And that was the day my mom had my youngest sister at home, and I watched her bring her into the world. Here we are with my siblings. There's 7 of us on earth. My mother, unfortunately, lost 2 babies via miscarriage, which I will touch on as well. I am a family physician with MD for Life. I am a teacher. The word doctor comes from the Latin docere, which means to teach, and I'm privileged to teach students not only through my role at Georgetown and at Duquesne, but through our work at Facts About Fertility, of which I have served as co-founder and executive director. So, with that as a framework, let me jump in to the talk. I'll begin with definitions. We're going to talk about the safety of IVF versus restorative reproductive medicine, the effectiveness of both, and the affordability, and then talk about opportunities for training. So here are my objectives. One, we're going to define terms. We've been talking about infertility and fertility and restorative reproductive medicine, so I plan on defining all of those as well as some other terms. We'll talk about how RRM, or restorative reproductive medicine, is safer alternative than conventional approaches to infertility treatment, including IVF. We'll talk about how effective they are in comparison. I know that was one of the questions that somebody had asked during the earlier session. I'm going to share some studies that look at that. And then we're going to talk about the effectiveness and affordability. I'm going to highlight just data from the mainstream medical literature as well as from my own patient practice. So before I dive in, though, I think it is important that we are on the same page when it comes to fertility. Like, how are babies made? I mean, if you ask most fertility doctors, they would say in a test tube, right? What is needed to make a baby? Most people recognize that you need a sperm and an egg. The sperm is the paternal contribution, and the egg is the maternal contribution, and those are critical. But what is also critical to natural fertility is fertile cervical fluid. And this is actually something that, and correct me if I'm wrong, Dr. Burke, most of the REI doctors miss. I like to say that fertile cervical fluid is the elixir of life. And what do I mean by that? I mean, it is essential for life. Why is that? It has to do with the lifespan of the sperm and the lifespan of the egg. And the presence, when a woman ovulates and releases an egg, the egg is available for 12 to 24 hours for fertilization to occur. That's it. And a woman, on average, will ovulate 12 to 13 times a year. So imagine if the men had to find those 12 or 13 days a year, and you'll see in just a minute, the probability of pregnancy in any one cycle is very low. Imagine if they had to find that time. Not for nothing, guys, your timing is just not that good. But in the presence, and it has to do with the lifespan of the sperm, in the absence of fertile cervical fluid, sperm will die within the woman's reproductive tract within 6 to 12 hours. It is a very hostile environment and inhospitable for sperm. But in the presence of fertile cervical fluid, sperm can survive for up to 5 days. So that's why it is so important. It's simple, but it is powerful. I like to share a story. I spent most of my career working in Washington, D.C. I still do, even though I live in Lancaster, Pennsylvania. But the first few years I worked at a federally qualified health center where I served a mostly uninsured, low-income population. And I had a couple come to me because they couldn't get pregnant. And they were young by, relatively speaking. She was 26, 27, he was 30. So really at the prime point in their fertility lives. And the husband had had a child from a previous relationship, and so the wife thought that there must be something wrong with her. They had been trying over a year, so met the definition of infertility, but could not conceive. And her concern, as she expressed to me, was that, not only was she not able to conceive, but she continued to have this recurrent infection, month after month after month, where she would get this discharge. And whenever she got this discharge, she never had sex with her husband because she didn't want to give him whatever illness it was that she had. I know, I see the women laughing, really? And I did the same thing. I'm like, could it be that easy? Being a good family doctor, I did the full workup and she had no underlying issues. And I said to her, I'm like, humor me. Just the next time you have that discharge, as you will, have sex with your husband. And the only thing you will give him is a baby, I can guarantee it. 2 months later, they came back pregnant and they thought I was a miracle worker. But what I did is I simply educated her about how her body works. If they were not Medicaid patients, if they had really good insurance, this is Washington, D.C. There's an IVF center on practically every block. She would have been shunted to the IVF industry and then we were successful in helping you get pregnant. No. So it's really important. When we understand that concept, the lifespan of the egg and the lifespan of the sperm, we understand the fertile window. So what is important to note is women are almost always biologically infertile. That is, most of the time, women are not able to conceive. Healthy women with regular cycles. Men, on the other hand, are almost always fertile. And when we look at a couple's fertility, we look at the reproductive system. The reproductive system is the only system in the human body that to function to its fullest capacity requires cooperation with another human being, right? Women cannot reproduce on their own. Men cannot reproduce on their own. It's the union of man and woman, that cooperation that allows for them to reproduce. And that is determined by their fertile window, which, as I noted, is about 3 to 6 days, and that depends on the lifespan of the egg and the lifespan of the sperm and the presence of fertile cervical mucus. So how can women and couples learn to identify that fertile window? Through tracking their cycle with fertility awareness-based methods. With fertility awareness-based methods, women can learn to observe specific biomarkers or signs to be able to identify that window of fertility. This emphasizes importantly the understanding of fertility, but it can also be used for monitoring health. And I am a strong proponent and a big believer that we should be teaching young girls when they go through puberty to chart their cycles. Not for the purposes of family planning, but for the purposes of understanding and appreciating the way their body is designed and to monitor their health. This term can be used interchangeably with the term natural family planning. I like to say the difference is natural family planning focuses on, this is really about family planning, but fertility awareness-based methods can be used by anyone. I have adolescent girls that chart their cycle. I have married women that chart their cycle. I have religious sisters that chart their cycle. Some do it for various reasons, but again, the term fertility awareness-based methods and NFP can be used interchangeably. Here's just an example of the signs that women can learn to chart. Again, cervical fluid probably being, if not the most important sign. It's incorporated into most of the methods. Basal body temperature, urinary hormones, and then also the days of the cycle can all be integrated into the different methods of family planning. This is another really important basic point for everybody to understand when it comes to fertility. The probability of clinical pregnancy resulting from intercourse on certain days relative to ovulation in a healthy woman, that's what we're looking at here. 1 to 2 days before, skipped ahead. 1 to 2 days before ovulation, it is as high as 25 to 28%. Meaning most cycles, when a couple has sex during the fertile window, they're not likely to get pregnant, okay? And it's the day or two before ovulation. So when couples use LH strips to say, oh, I ovulated today, let me go home and have sex, like you're already almost approaching 0%. So that's really important because oftentimes I'll see women, I'm doing these LH test strips, I'm not getting pregnant. I'm like, well, if you're waiting until the strip tests positive, you may be missing that narrow window. Okay, so I've been touching on, and obviously the topic of today is infertility. Let's define what is infertility. Infertility refers to the inability to achieve pregnancy technically within 12 months of random acts of intercourse in women younger than 35 years. Now, what the medical reference textbooks refer to as infertility women over 35 is they recommend considering women infertile after the age of 35, in part so that we can get started sooner on the treatment. And again, conventional medical treatment is, moving them down the road of ART. Another important note is in couples that are charting their cycle and they are identifying that fertile window, if they are engaging in sexual relations month after month after month in that fertile window, we consider them infertile after 6 months. But it's not just an inability to conceive that matters. It's the inability to carry to term. And that's really, really important. And this is referred to as impaired fecundity. It's not only difficulty in getting pregnant, but difficulty in carrying a pregnancy to term. And then we also can talk about primary infertility. This is a couple who's never been able to conceive, or secondary infertility. They may have been able to conceive and carry to term, but for some reason are not able to conceive again. Why is this important? Why is this relevant? Well, these are very, very common conditions. Impaired fecundity is nearly up to 30%, primary infertility is upwards of 20%, and so on. Another really important point that I think Dr. Burke alluded to, and I want to really drive home, is infertility is not a woman's health issue. It is a couple's issue. When couples are struggling with infertility or impaired fecundity, it is often multifactorial. 30% of the time we find something wrong, some underlying problem within the woman. 30% of the time there's a male factor. 40% of the time it's both, which means 70% of the time there may be something that needs to be diagnosed and treated within the male. 70% of the time there needs to be something diagnosed and treated within the woman. So it's really important that we recognize that, and we're looking at both the male and the female. And that's one of the reasons I like being a family physician, because I'm comfortable with seeing men. Unlike my OB/GYN colleagues who are like, why don't you go see a urologist? When in reality, a lot of the male factor issues are things that we do well as family doctors, managing high blood pressure, cholesterol, weight, etc., which can contribute. Another important thing to note is infertility itself increases a person's risk for other diseases. So by treating the problem of infertility by creating the baby in the test tube, you haven't actually treated the infertility. So you haven't actually overall improved their person's health. And this is something I say to all of my patients that come to me with subfertility or impaired fecundity. I tell them my goal is to not help you have a baby. That is not my goal. Only God is the author and the creator of life, and he can use me as a tool to facilitate that. My job is to optimize your health, to optimize the woman's health and the men's health so that, God willing, they would be able to procreate naturally. And I'm going to share data from my very own practice on how we do that. I wanted to highlight some of the causes of infertility, which you can see here, the male factor, the female factor, factors within either partner. This is what's typically listed, but this figure actually comes from a study by the Kaiser Family Foundation. And they actually talked about the reasons people may seek fertility assistance. And as you can see, it's for way more than just infertility. People aren't going to pursue IVF just because they're infertile. They may be going because they're in a same-sex marriage, right? They may be going because they had to have a cancer treatment and that may have affected their ability. So there's a number of reasons. But what interestingly is missing on this slide is miscarriage. And I want to touch on that point. These are a couple of slides I added this morning. I know poor Eileen and William were like, when are you going to have your slides for Dr. Duane? I'm like, I am updating as we go. So I wanted to put on these slides on miscarriage because miscarriage is really, really important. Like IVF, it's an incredibly sensitive topic and it affects many, many people. I started this talk off by talking about my two brothers who my mom miscarried at 8 and 12 weeks and the profound impact that had on me in my work. In fact, during the pandemic, I thought it would be a great idea to move my family of 6 from Washington, D.C. to Salt Lake City, Utah, so I could do a research fellowship in which I actually studied miscarriage, looking for what are modifiable risk factors of miscarriage that we can treat. And I'll talk about this in just a second, why it is important. Miscarriage very simply refers to the spontaneous loss. Sometimes it's coded as spontaneous abortion, which creates all kinds of problems. I got called in by the Archdiocese of Washington with their health insurance plan because a person was getting treatment for spontaneous abortion. And what does this mean? Could they cover that? I'm like, yes, it's a miscarriage. But it refers to the loss, spontaneous loss of a pregnancy between 5 to 19 weeks gestational age. An early pregnancy loss is referred to as a loss before 10 weeks. And this is really important because you can have losses before 5 weeks gestational age. Let me just talk to you about how we determine gestational age. The gestational age is not the weeks of the embryo's life, right? The embryo's life begins at the moment of fertilization, but it actually is determined by adding 2 weeks to it, assuming that women ovulate on day 14, we calculate gestational age by the last menstrual period, so we add in 2 weeks plus the actual age of the embryo. So at about 3 weeks embryonic age, a woman is 5 weeks gestational age. Does that make sense? So that's a really important thing to know. Why? Because oftentimes it's difficult to determine whether a woman is pregnant even before 5 weeks gestational age unless she's charting. And I've diagnosed miscarriage in women who are 4 weeks, 2 days pregnant. That comes up when we talk about the incidence. And this is a little bit what I'm talking about. Peri-implantation loss, which are sometimes referred to as chemical pregnancies, which I think is a horrible term and can be very traumatic to a woman that has lost a baby because her baby is not a chemical. It's referred to as a chemical pregnancy because it's only able to be detected by measuring HCG hormone levels, the chemical test. But it is in fact an embryo at a very early stage. So I encourage my students to refer to those as preclinical losses. Recurrent miscarriage refers to 2 or more pregnancies, lost pregnancies before 20 weeks. So, where am I going? There we go. So, and that went a little too fast. Incidence of miscarriage. This is really, really important. What I want to hone in on is the percentages. Oftentimes miscarriage, we learn, happens 15 to 20% of the time. Now 15 to 20% may not sound like that much. I mean, that's about how high infertility rates are. But I teach my students, you have to ask yourself, what is it 15 to 20% up? What are the actual numbers that we're talking about? And in 2022, there were 3.7 million, it's percent of live births. In 2022, there were 3.7 million live births. So 15 to 20% of 3.7 million is about 500,000 to 750,000 babies are lost via miscarriage. Now in the United States of America, we do not count or track miscarriage as a cause of death. How do we define death? The cessation of the heartbeat. The heart starts beating at 5 weeks gestational age. So if you have a miscarriage between 5 and 20 weeks, you have the cessation of a heartbeat. We rightfully should be counting this as a cause of death. And if we did, maybe we would take it more seriously. Why? If we tracked miscarriage as a cause of death, it would be the 3rd leading cause of death in the United States of America, after heart disease and cancer. And when you think about everything we do in our country to prevent heart disease and cancer, it's a lot. In medical school, we learn you don't do anything for a woman who's had a miscarriage until she's had 3 miscarriages. Now, I shared with you I had 4 children. I wouldn't wait until I lost 3 of my children to say, well, what can I do to prevent another loss, right? And so I really want to make sure that we're mindful of this, because it's not just about not being able to get pregnant, but it is about being able to carry to term. And I think Anne did a beautiful job last night during her talk, talking about women who've experienced miscarriage and recognizing them as mothers and recognizing the loss that they've experienced. Why do we not do anything, or why do we not teach future physicians how to address miscarriage? Well, my colleagues will say 50% of the time miscarriage is due to a chromosomal abnormality. It's a genetic defect and you can't do that. Yes, 50% of the time it is, but that means 50% of the time it's not. So if we're looking at 500 to 750,000, well, there's 250 to 325,000 pregnancies that we could have potentially saved, right? More importantly, when women have recurrent miscarriages, the likelihood that the underlying cause is genetic drops dramatically, and much more often it's due to maternal anatomic abnormalities, hormonal imbalances, endocrine issues, infections, autoimmune factors, things that we can identify, prevent, and treat. So it's really important that we keep this in mind as well. So I have two questions that I want you to consider, and I know we've touched on these a little bit earlier on, but the first question is infertility a disease or is infertility a symptom? So IVF treats infertility as if it's a disease. So the disease is you can't get pregnant, and our solution is we are going to create the embryo, right? And if that was all, then IVF should have a 100% success rate once they've created the embryo. But the reality is, as you'll see, the success is not nearly as much. Restorative reproductive medicine, and even medicine in general for many, many years, identified infertility as a symptom. It's not simply a disease, it's a manifestation of oftentimes many other diseases that have led to this place. And then again, I think my colleagues this morning did a beautiful job addressing this question: is having a baby a right or is it a gift? And again, I think, the IVF industry would argue it's a right, whereas in the RRM focus, we recognize that it is a gift, and that, as physicians that practice this, we don't give this, only God gives this, and we can be used by Him. Now, what's interesting is the ASRM, the American Society of Reproductive Medicine, which is really, they just came out with a statement criticizing restorative reproductive medicine, but ASRM 20 years ago identified infertility as a symptom and wrote an editorial saying it's a symptom. Now they've changed tunes and are calling it a disease. So I just wanted to point that out. So let's talk about approaches to infertility or impaired fecundity. We've been talking about these all day, the conventional approaches of IVF, IUI, etc., versus restorative approaches. Personally, I am trained as a naprotechnology medical consultant, as a fem medical consultant, and as a near-fertility medical consultant. These are the only three medical approaches that take a restorative reproductive approach to underlying the treatment of infertility and other reproductive health issues. And I'll just make this point, I made this last night. With IVF, the goal is to treat infertility. With restorative reproductive medicine, the goal is to optimize health. And in doing so, infertility is one of the diseases that we treat, but we treat all kinds of issues and people of all ages and stages of life, not simply those struggling with infertility. And again, we do this through restorative reproductive medicine. So let me define this term formally. With restorative reproductive medicine, we seek to identify, diagnose, and treat the underlying issues of reproductive dysfunction, including infertility. It's an approach that does not employ methods that are inherently suppressive, destructive, or circumventive, and it respects the integrity of the human person and the marital relationship and the rights of the couple to work with a medical professional to help them identify and treat the underlying issues. Questions on the definitions? All right, let's jump into the safety and looking at a comparison of options. So with restorative reproductive medicine, again, we investigate the why is the couple having trouble getting pregnant. We treat the root causes that are leading to the couple's infertility, and we're working with the woman's cycle to allow the couple to conceive in the natural marital embrace. With IVF, and I will use the term IVF and ART interchangeably because IVF comprises over 99% of ART. The goal is not to necessarily address the underlying causes, but simply to create the embryo in the test tube. It's expensive and it's often not covered by insurance, and it creates many, many ethical dilemmas, as we've already been discussing today. This was a picture that a woman who had gone through IVF took of her baby girl with all of the needles that she had used to conceive and carry that child to term. This is the experience of a couple that is going through RRM. They're working with clinicians that are looking at the science underlying her cycle and his health to hopefully help them achieve their goal of having a child. But to be clear, it is not always successful. And to me, as a physician, that is the most difficult thing. I recently did a podcast on the Hormone Genius podcast, and the title of the podcast was, I Got My Period. And that sounds like a very simple statement, but I have had patients text me that statement, and I burst into tears because I know it's another month of trying, and that sign that it didn't happen this month, and it breaks my heart. When I talked about that on the podcast last week, it was because I had a patient text me the week before saying, I got my period, exclamation point, exclamation point, exclamation point. She was a patient I began working with in June. She hadn't had a period in 17 years and was told she would never have a normal period. And when she wanted to have children, was told she had to do IVF. And she did do IVF because she didn't know any different. Even after having her children and recognizing, wait, ovulation is a sign of health. I'm 40. Can I still get my period? I'm like, yes. So, you know, those four simple words can evoke such a strong range of emotions, you know, not only for me as the physician, but no doubt for the patients. So I wanted to talk about this safety, and this is something I don't think couples are really well informed about, the risks associated with artificial reproductive technology. Risks including preterm birth, hypertension, preeclampsia, gestational diabetes, large for gestational age babies, severe maternal morbidity and mortality, including postpartum hemorrhage, etc. Ovarian hyperstimulation. This is a picture of an overstimulated ovary. Unfortunately, like with women who donate their eggs, I mean, there have been stories of women who have, you know, out of the goodness of their heart and possibly the financial remuneration, decide to donate eggs and end up you know, suffering, sick, hospitalized, and some even passing away due to ovarian hyperstimulation. So it's very, very complicated and risky. There's also risks to the children who are born after ART. Increased risk of genetic disorders, non-chromosomal birth defects, autism is higher, cerebral palsy, stillbirth. There's also increased risks of certain types of cancers. When I was doing my research fellowship in Utah, one of the other PhD students was actually looking at this very topic, the increased risk of cancers in children conceived and born via IVF. But it's not only the risk to the children who are born after ART, it's the risk to the embryos, and we've already touched on this. There's research showing that for every live birth, there are 9 eggs that are retrieved, 4 embryos that are created in order to create the one child. What happens to those others, right? And not only what happens to the ones that don't survive, what about the one that does survive and is living with that knowledge that she survived or he survived when their siblings didn't? There are many ways in which the embryo can be destroyed, whether they're discarded or human error, as Teresa talked about with the Alabama case, suboptimal conditions for growth, the manipulation, the storage. So there's many risks to the embryos. Okay, let's switch gears now. Eileen, how much time do I have?
11 minutes.
11 minutes. Okay.
Yes.
We should begin. All right, now I want to switch gears to talk about the effectiveness. We'll talk about the effectiveness of ART versus RRM. So to be very clear, IVF does not guarantee a live born baby, right? Even though they're creating the embryo, it is not 100% success rate. And it's important that we look at how we calculate the statistics. So if you're looking at live infants born over embryo transfers, it's a 45% success rate, and this is based on data from the US in 2020. But that doesn't look at all the embryos created. If we're looking at all the embryos created, the cycles performed, it's 35%. And again, this is US data. I'm gonna help dive deep a little bit more using data from the UK on these next few slides. You know, so similar, lower numbers obviously, but I think this is from 2021. You know, they looked at live births versus embryos transferred, and they said it was 1 in 3 because it was 14,000 live births over 42,000 embryos transferred. So that sounds great, 33%. But when you look at cycles performed, 48,000, it's actually only 25%. Okay? And this is how they do it. Like, this is just as an example for in 100 cycles, you might have 13 eggs that were retrieved, or no embryos were transferred. So they take those out. So you're not looking at a denominator of 100 now, you're looking at a denominator of 87, because you're only looking at the ones transferred. They're also not looking at the miscarriages. They're saying how many women got pregnant, right? So 29, I can't even read the numbers there. Yeah, 29 clinical pregnancies. So they're saying it's 29 out of 87. So again, it's the manipulation in the numbers. So now to help give them higher success rates. But we take out the miscarriages, you're actually looking at fewer live births, which is really the success. Because to the couple that's struggling with infertility, the goal isn't did I get pregnant, the goal is did I go home with a baby. So with restorative reproductive medicine, we have comparable, if not better, birth rates than those studies. This is one particular study. I'm going to quote a lot of data from my colleague, Dr. Phil Boyle, who developed the neofertility method. This is a study he published in 2018 in patients he had treated who had all gone through IVF. And on average, the couples he had treated had gone through 2.1 cycles of IVF without success. What he found in treating them with the restorative reproductive medical approach is that he had a 32% live birth rate in couples who had failed on average 2 cycles of IVF. He just published another study literally just last month. So the teal is his data, the dark blue is data based on IVF data with multiple embryo transfers, and the orange is based on data from single embryo transfers, and you can see across the board his success is higher. And it's not only are they going home with babies, but arguably they're much healthier because we're treating those underlying issues. And this, I think, highlights it beautifully. This is a table, and I apologize if you can't really read it tremendously, but the first column lists the different types of conditions. The second lists the percentages found based on the CDC, and then looking at what we see with RRM. And you can see for the CDC, there's a lot of it where they're not even reporting these underlying causes. Why? They're probably not even looking for them. You know, you can't solve a problem until you identify the problem, but they're not interested in treating the underlying causes. That's not going to serve them well, it's only going to delay them. Whereas with a restorative reproductive approach, we are going to work through and systematically identify and treat every single issue. And the challenge with IVF, I think, or the challenge with RRM as compared to IVF is IVF offers that quick fix. RRM is a much more time-intensive process because there's so many things that we need to change. Oftentimes, lifestyle changes can be a contributing factor, and those can be a challenge to address as well. But when we diagnose and treat it, we look at each of these factors. We look at male factor, we look at female factor, we look at the cervical factor, the sexual factor. I mean, again, are they having sex at the right time? We look at the anatomical factors. And although I'm not a surgeon, I've had patients with issues that fall into each of these categories that I'll work with my colleagues to make sure we treat them effectively. This table comes from a paper that I published in 2022 with my research mentor, where we look at how the chart, just the simple act of charting the cycle, can help us identify some of those issues that we can then treat. So this is one study that looked at the treatment of infertility, looking at family physicians who were trained as NAPRO medical consultants, and we used NAPRO to diagnose and treat it. The patients were trained to chart with the Creighton model. And we evaluated the outcomes that matter to patients, that is, live births. You can see in this study, before their NAPRO evaluation, almost half had unexplained infertility, which, as I like to share with my medical students, unexplained simply means we have not done our due diligence as doctors to make the diagnosis. The fact that almost half of these women would not have a reason, that's simply unacceptable. And as you can see, after their NAPRO evaluation, it was less than 1% had unexplained infertility. So really, really important that we're looking at this. And oftentimes, many of those factors are factors that can be relatively easy and effectively treated to help couples achieve their goal. In this study, where the average age was advanced maternal age at 35.8, couples have been trying for over 5 years. The live birth rate was 52.8 per 100 couples. There was a follow-up study by Dr. Thayam et al. That showed even better results, about 66 live births per 100 couples. Again, it's not an apples to oranges comparison, but couples that use NAPRO technology and work with NAPRO medical consultants have live birth rates comparable, if not better. This table comes from that same 2022 paper, which I have copies of back at our table if anyone wants to take this with them, that just shows the effectiveness in various studies using fertility awareness-based method tracking and restorative reproductive medicine. Here's data from my very own practice. So I have a very small practice in our nation's capital where I do all house calls. In the last 3 years, I've had 39 couples present to me with infertility or recurrent miscarriage. As you can see, the overwhelming majority are over the age of 35. And they came in with a lot of medical issues, many issues that I was able to address. We just presented this data, the poster is in the back for anyone looking, but of my 39 patients, 34 of them have conceived. We have had 48 actual pregnancies because some of them have conceived more than once. We currently have a 57% live birth rate with 27% ongoing. I expect our live birth rate to be upwards of 70%. This is a very small practice. I mean, yeah. And these are not easy patients. Like, these are couples that have been trying for years, that have had miscarriage after miscarriage. I had one woman who had 3 children, had 5 miscarriages, and she just gave birth at the age of 42. So it's really incredible. Here's just some of the many cases. I'm not going to go through all of these, but I want to highlight one in particular, and this is the last one, and this is kind of a follow-up to the question during the Q&A about embryo adoption, that conundrum. So the last patient, ND, is a 42-year-old who had 2 healthy, normal children in her first 2 years of marriage. She and her husband, salt of the earth people, the exact people that my medical colleagues think can't use NFP because they're lower income, Black, live in inner city DC, but he works for the church. She's a stay-at-home mom raising their children. They had 2 beautiful children, really hoped to have more children, had secondary infertility. I think honestly it was primarily due to the husband and his weight issues. He wasn't willing to do much, and so they decided to do adoption, and they adopted a boy through the foster care system, and so they had a 13-year-old daughter and an 11-year-old daughter and a 1-year-old son. And they really wanted to adopt again because they didn't want their little boy to grow up without anyone. The challenge was with the foster system in DC is they could have a child's place and then taken away. And they thought that would be very traumatic for their 3 children, so they wanted to consider doing embryo adoption. And they asked me my thoughts, and I'm like, that's a really difficult issue. And I actually had a coffee with Melissa Moschella to have a conversation with her. Ultimately, they did decide to adopt 2 embryos, but because of who they are, they decided to choose the 2 embryos that had the least likelihood of being adopted, because they were created in 2003 by a mixed minority couple. So they had the embryos transferred, they followed the IVF doctor until 12 weeks, and then they were discharged, and then her hormones plummeted. The first embryo had not survived the transfer, but the second did. And when she came to me, we started her on hormone support. Interestingly enough, she delivered a baby boy on August 11th. What I later found out was the family from whom they adopted these children had created 5 embryos. The first embryo that was transferred never took. They then had 2 embryos transferred, the biological parents, and that pregnancy did take until she delivered prematurely at 21 weeks, 2 baby girls that died within hours. Those girls were born 20 years to the day that their brother was born, which to me, I'm like, if there is not a God, I mean, it was just, and I remember this is when I did his 1-week well child check, and I'm holding this child and looking at him and thinking, next week I am taking my son to college, and he was born a year after you were conceived, right? Just, there's a lot there. I mean, I will say even as a doctor. So let's talk about affordability. I only have a couple of slides. I don't need a lot. Very simply, IVF is incredibly expensive, especially when you get into using donor eggs, but even without donor eggs, it's upwards of $50,000. Whereas when we use restorative reproductive medicine, it's much less expensive. And this is an example of one of my patients and one of my success stories. So this is a 40-year-old woman that came to me in November. She was referred by friends of hers who had conceived working with me after 4 years. She had done IVF because she was told she would never conceive naturally. And when she had done IVF, they had created 8 embryos. 1 was transferred that she carried to term, gave birth to a baby boy. Then afterwards, they transferred 1, it failed. They transferred another, it failed. She was told the 5 remaining embryos were genetically inferior and were not worthy of being transferred, and that she needed to do ovarian egg retrieval again. And she was scheduled for that in November when she reached out to me. At this point, I'm like, I'm not taking on any new patients, but I cannot say no to this woman because otherwise, where am I leaving her to be led to? So I talked to her, I saw her in December. Right away, I could tell she had issues that we could treat: insulin resistance, thyroid. She had a history of endometriosis, so I referred her to a surgeon for endometriosis surgery. This was her timeline. So again, 5 years of IVF, she has 1 child. She started with me in December. We treated her underlying medical issues. She had surgery for her endometriosis in March, and she conceived in April. She's now 26 weeks pregnant. But from a cost perspective, she estimates her IVF costs for $50,000 to $55,000, and her cost for doing restorative reproductive medicine, including the surgery, was $6,000 to $8,000. So again, it can be incredibly more affordable. I highlight this family. This is a couple that had struggled. They had primary infertility and then were able to have their daughter, and then struggled with secondary infertility and then recurrent miscarriage. And we worked together, and she had surgery, and she gave birth to their beautiful baby boy. Their beautiful baby boy, the second child. And then a year later, she texts me, she's like, Dr. Duane, I'm pregnant. I'm like, congratulations. She's like, how did that happen? I'm like, wait, really? Do you have to go there? She had done nothing extra to get pregnant with the third. I was like, well, we restored her reproductive system to the way that was designed to function, and lo and behold, it functioned because we treated the underlying causes that contributed to her infertility. You know, now she's not out of the woods. You know, unfortunately, she just experienced another miscarriage, which, you know, was devastating. But the fact that this can be so affordable, because when you treat the underlying issues, oftentimes you can successfully have additional children. So the last couple slides is on the need for training. So somebody said to me, you said to me, we need 100 more of you. I'm like, I'm working on that. Because we need 1,000 more or 10,000 more. In Pennsylvania, there's about, I can probably count on one hand the number of doctors that do restorative reproductive medicine. One hand, right? I mean, in an IVF center in Philadelphia, there's probably at least, you know, that many REI doctors. There is such a dearth of doctors that are trained to do this. Why? This is not taught in mainstream medical education. That is, until we started FACS in 2010. At that time, there was a study that showed only 3 to 6% of OBGYNs and family doctors were familiar or knowledgeable with any of the modern fertility awareness-based methods. So I started teaching a class at Georgetown to 9 medical students, which is now evolved, that we've taught in the last decade over 1,000 medical students from over 100 different medical schools. And we're method neutral. We teach about all of the methods that have solid scientific evidence to support their use. And different methods will work well for different individuals or different couples depending on their goals. The good news is last year, Duquesne University College of Osteopathic Medicine welcomed their first class of medical students. At the same time, they launched the Center for Fertility Awareness Education and Research, and they hired me to integrate this training at every level of the medical school curriculum. So now we have at least one medical school where all of the students will learn this as a standard part of their medical school curriculum. But we are still a far cry away. So we work to help promote and encourage people. We are going to be launching, for any medical professionals in the room, a neo-fertility cohort training next week. We'll be launching a FEM cohort training later on this fall. Our goal is to help train more and more medical professionals in this. We offer a medical school elective, which is also open to nursing or other health professional students. We currently have a midwifery student enrolled. It's a great opportunity for students. We also have a continuing medical education course for medical professionals. I'm trying to take a page from the playbook of NCBC with their certification program and look at doing something similar for medical professionals to get certified in a general certification in restorative reproductive medicine. And then last, I will say, we are doing an upcoming virtual conference in 2 weeks on lifestyle for healthy cycles. At FACS, typically our focus is on educating the medical professional community, but this conference in particular is going to appeal to a larger audience because we're looking at nutrition and sleep and exercise and stress and how all of these can affect fertility, both in the woman and in the man. So this is a great opportunity for anybody who is interested in sharing. Our Friday night presentation is actually going to be on physician wellness and infertility because unfortunately, female physicians are the single group with the highest rates of infertility. Because they're stressed and they're not sleeping and they're really not eating well and probably not getting nearly enough exercise or too much. I put this up, this was where I came up with the title for this talk, Restorative Reproductive, a safe, healthy, and effective alternative. I should have, if I had my act together, and if this wasn't the 12th presentation that I've given in the month of September, might have sent this to be included in your folder, but I didn't. I do have a few copies of these back on our table, but this is available on our website, and it really just is a very succinct summary of my talk today. So, thank you.